Hi, I'm Raajit Rampal from Memorial Sloan Kettering Cancer Center, and I want to talk today about diagnosis and prognosis in MPNs. And my intention in our talk today is really to give you some more granular detail about how we approach the diagnosis of MPN. A lot of tests are done when a patient is diagnosed, and it's not often that we sit down and discuss with patients, why are we doing the tests, what are we learning from the tests, and what do they mean? And I hope to kind of demystify some of that for you today in the context of MPNs overall, and then talk a little bit about some of the important questions I think it's that patients should ask their physicians as they undergo diagnostic testing. So, MPNs are really a continuum of diseases. We put things into discrete boxes and say, people have polycythemia vera and essential thrombocythemia or MF, and these all have strict criteria based on consensus guidelines in terms of how they're diagnosed. On the other hand, it's also important to realize that not every case fits conveniently into one box, meaning that there are patients who still for example, they had polycythemia vera and they progressed to myelofibrosis, but they still potentially have some features of polycythemia as part of their disease, so they don't conveniently fit into one box. Sometimes we have trouble making a diagnosis because not everything fits conveniently into one box. And so I think it's important to realize that, yes, there are strict criteria to make certain diagnoses, but there are certainly cases where we don't have all of the pieces fit quite right. And in those cases, the diagnosis may not be clear. Now, how do we make our diagnoses? And what are some of the tests that many of you as patients have undergone? One of them are bone marrow examinations. So these are bone marrow biopsies and associated tests. So let's break this down and talk about what these tests are. What do they mean? What do they tell us? The bone marrow exam consists of two things. One is the bone marrow aspirate, where we actually take a little bit of the blood from within the bone marrow cavity. The outside of the bone is hard. The inside is sort of spongy where the bone marrow and blood production actually occur. And within that cavity, there is blood, and that's what we take, what we call the aspirate from. And then there's the biopsy, and the biopsy is the piece of bone that we take. So it's the larger needle that we take a solid piece of the bone. And these two things tell us different things, as we'll talk about in the next few minutes. The aspirate allows us to look at the cells that come out of the bone marrow and to do a number of different tests that are listed below, and which I'll talk about in a moment. And the biopsy lets us look at the cells in the context of the bone marrow, but also to do things like look at how many cells there are in the bone marrow and whether or not there is fibrosis or scarring. So all of these tell us different things. Now, what are some of the associated tests that we do with the bone marrow examination? One is a chromosomal analysis, and this is termed cytogenetics. So chromosomes are essentially larger structures that contain DNA, and they contain proteins. It's all the DNA that encodes essentially everything that helps us function lies within the chromosomes, and different genes are on different chromosomes. The JAK2 gene, for example, is on chromosome 9. And so the cytogenetics tell us, is there some structural change in the chromosomes? We do see this more frequently in patients with myelofibrosis or more advanced diseases where pieces of the chromosomes may be missing, or there may be an additional piece of chromosome. It does have prognostic significance, and in some types of diseases, it actually is of diagnostic importance. The next test that we often do are mutation testing, or what is termed NGS. You'll hear that a lot. NGS stands for next generation sequencing. And the sequencing is there to tell us whether or not mutations have been acquired in specific genes. So the big picture, chromosomes have multiple genes on them. And then the mutation testing tells us, are there actually abnormalities within a given gene? And most of you who have MPNs are aware that we test for things like the JAK2 mutation or the MPL mutation or the calreticulin mutation, all of which help to define if somebody has an MPN. And so that's mutation analysis, and we'll get more into that. We look at the bone marrow cellularity, which is the ratio of cells to fat in the bone marrow. And that tells us a lot in terms of what the diagnosis might be. We look at bone marrow fibrosis. And we also look at the morphology of the cells, and that means how do the cells look? And that is a diagnostically important test because certain cells are abnormally shaped in certain types of MPNs. A good example of this is in essential thrombocythemia, there are cells called megakaryocytes, which give rise to platelets, and they are very abnormally shaped in a very classical way in the bone marrow of somebody with ET, and that helps to tell us that the patient has ET and not a different disease. So let's go through some examples of this. So first is karyotype. Anybody who's had kids is probably familiar with karyotype because this is something that's done as a screening test when someone is pregnant. But the karyotype is important for bone marrow diseases too, because it can have a prognostic importance if patients have abnormalities in their chromosomes. So you have 23 pairs of chromosomes, and we look to see if they're the same or if there's anything missing in the chromosomes. So on the left, you see a normal karyotype. You see that essentially the two pairs of chromosomes are the same for all of the pairs. But if you look at the one on the right, you see that this is an example where somebody has a deletion of part of chromosome 7. If you compare the two chromosomes. And that is something that we frequently see in people who have more advanced diseases like acute leukemia, but sometimes in more advanced myelofibrosis, we see this. And that does have prognostic significance. So this is the type of information that we get from the bone marrow aspirate, followed by some other testing. That does give us information about the disease. So let's go next to mutations. What are we talking about when we talk about mutations? Well, when we think about the overall biology of how proteins are made, the DNA, which again is part of the chromosomes, gives rise to something called RNA, and the RNA ultimately is the instructions or the blueprint for how to make proteins that are the much of the structure of cells and other things. So the DNA is composed of 4 base pairs, G, C, A, and T. And the different orders of these base pairs encode for different proteins, essentially. When somebody has a mutation, this can mean that there has been an alteration in the DNA, and this can take a number of different forms. This can mean that, for example, if you look at the top, that one base pair has substituted for another. So instead of G, C, A, and T, now it's G, C, C, and T. It can mean that there is new genetic material that has been inserted. And so you see, deleted or inserted, actually. You can see that, the middle column, in this case, there's a bunch of genetic material that has been deleted from this individual's DNA. Now, at the bottom, you see that there's an insertion of G, C, and G into somebody's DNA sequence. So these are all things that are consistent with what we call somatic mutations. And again, there are certain mutations that define MPNs, as we talked about, JAK2, calreticulin, and MIPL mutations. But there are certainly mutations that occur in a number of other genes that are of importance in MPNs prognostically, and in some cases actually therapeutically. But this is additional information that we get from the bone marrow, but we can also actually get this information from the blood. Next, let's talk about the bone marrow biopsy. So the biopsy, remember, is a solid piece of bone that is taken out when we do the bone marrow testing. And this is a microscopic image of what actual bone marrow core looks like when from the needle biopsy. And on a high level, what you're looking at is that there is parts of the structure of the bone that you can see here, but then most of it is really just the cells and open spaces that are fat. And if we drill down on this picture further, so if we take a closer look at this picture, this is what we see. And the bone marrow is essentially comprised of cells and fat. Now, one of the things that we look for is the ratio of cells to fat. Then that gives us what's called the cellularity, or the relative amount of cells in the bone marrow. The cellularity for most people should be 100 minus their age. So if you are 50 years old, you should have 50% cellularity. If you're 60 years old, you should have 40% cellularity. In other words, as you age, the relative cellularity should increase and the amount of relative fat increases. However, in certain of the MPNs, there is an abnormal amount of cells. And an example of that is here, where you see that essentially the bone marrow is entirely mostly composed of cells with very little in the way of fat. And this is the type of thing that we tend to see in patients with myelofibrosis and with polycythemia vera, whereas in patients with essential thrombocythemia, typically their cellularity is normal. That is part of how we make the diagnosis when we try to differentiate essential thrombocythemia from polycythemia vera, for example. And here's an example of just the opposite in somebody with what's called a hypocellular bone marrow. This is something where, there's very few cells and mostly fat in the bone marrow. This is not something you typically see in most MPNs, although in later stages of myelofibrosis, you can sometimes see this as the marrow becomes less and less functional. This is something that's more seen in other types of diseases, but an important consideration to how we make diagnoses. And here's some key examples from the various diseases. So, with essential thrombocythemia, here you see that there's sort of a relatively normal distribution of fat in cells, whereas in polycythemia vera, it's just the opposite. It's very cellular with very little fat. And the same thing is true in myelofibrosis. And what you also start to see in myelofibrosis cases, if you look at the structure, that you see that there's this sort of bent in the cells. They're not sort of smoothly overlaid as they are in panel B, but in panel D, you're actually starting to see that there's skewing in how the cells are sort of laid out. And that is often due to fibrosis in the bone marrow. So what is fibrosis? Well, let's take a look at that. This is a nice example of bone marrow fibrosis. And what the fibrosis are these strands here that are especially stained. And this is scarring. We rate fibrosis on a scale of 0 to 3, 3 being the highest grade, 0 being none. And this is an example of grade 2 or 3 fibrosis in the bone marrow. But again, even here, you can start to see that there's skewing of the cells with the fibrosis. And here's an example of somebody with grade 0 or 1 fibrosis, where you see very little in the way of these fibers and mostly cells without involvement with fibers. So that's an example of fibrosis. And again, one of the key things that we try to learn when we do a bone marrow biopsy. Now, let's talk a little bit more here about the genetics of the disease. So as I mentioned earlier, the MPNs are really driven by activation of what's called the JAK-STAT pathway. The JAK-STAT pathway is represented here. So this is the outside of the cell and this is the inside of the cell. And so signals come from outside the cell and they attach to receptors on the surface of the cell. Once they attach to receptors, they have to be transmitted as signals into the nucleus of the cell, which is the brain of the cell. One pathway that does this is the JAK-STAT pathway. Now, the JAK-STAT pathway is involved in the regulation of blood cell production as well as a number of other biological processes. But in MPNs, there is abnormal activation of the pathway. In other words, the pathway is being activated when it shouldn't actually be on. And this can be due to mutation in JAKs, which are proteins that live within the cell, and they can start to transmit signal to the nucleus when they shouldn't. This can also occur as a result of mutations in MPL, which is actually a receptor. And so it's supposed to take signal from the outside world and transmit it to the JAKs, but it becomes activated because of mutations in MPL when it shouldn't be. And then there's mutations in calreticulin. So calreticulin was really only discovered in 2013. And what we think happens right now is that calreticulin is a protein that binds to MPL, and when it's mutated, it activates it again in an inappropriate manner and causes the signaling pathway to turn on. So in essence, MPNs are really all driven by activation of this singular pathway. But there are other things that can occur. And so beyond just mutations in these JAK-STAT pathway, there are mutations that can occur in a number of other genes. And these genes are listed here. And the specific names I don't think are so important to focus on. But if you look at the percentage of patients here, most people have a JAK or calreticulin mutation, and then less frequently mutations in genes called TET2 or ASXL1. And then if you look here, under 3% of patients will have mutations in one of these other genes, some of which are really important in terms of prognosis of myelofibrosis, for example. But these are the types of information we try to understand and get when we do these assays or do these tests. So let's talk a little bit about the actual diagnostic criteria for polycythemia vera and essential thrombocythemia. So essential thrombocythemia is a disease whereby patients have high platelets and they can experience a lot of different symptoms. And this includes things like headaches, dizziness, burning in the hands, blurred vision. Occasionally, patients will have things like weight loss and night sweats, but not as frequently. And occasionally, people's spleens will be enlarged, but not frequently. The thing we worry about the most is with clotting, as well as bleeding issues. That is the most frequent complication of ET, although it can turn into myelofibrosis or it can turn into leukemia, but these are not frequent events. Now, one thing that I think we see frequently in practice is that a patient is seen by a hematologist and they have high platelets, and they do genetic testing from the blood. They find a JAK2 mutation, and they say, well, the diagnosis is essential thrombocythemia. That used to be the criteria for making the diagnosis, but there are other things that can look like ET, and the only way to distinguish them is to actually do a bone marrow. So one key example of this is something called prefibrotic myelofibrosis, which is an early form of myelofibrosis. Often patients will have very similar findings to a patient with ET. Their platelets will be high, and they'll have the same mutations. And so you can't really necessarily tell the difference between the two just by looking at the blood work. And here is where doing a bone marrow makes a difference because it can change the diagnosis. And changing the diagnosis can actually change what the prognosis is. If you look at the bottom of the table as an example of this, if you look at the incidence of, let's say, myelofibrosis at 15 years, it's about 9% in patients with ET, but it's closer to 17% if you have prefibrotic MF. And if you look at the 15-year survival percentage, it's 80% with ET, but it's 59% with prefibrotic MF. So the prognosis is different between these diseases. And the example of the bone marrow being different is shown here, where you see what an ET bone marrow looks like, where we have these cells called megakaryocytes that make platelets. These are abnormally shaped in people with ET, and you can see them up here. Whereas with prefibrotic myelofibrosis, there's an increase in the cellularity, and there's more of these megakaryocytes forming clusters. So the bone marrow, I think, is a really important test. And even in cases of patients with ET, there, I think, often remains a question as to whether or not it is actually ET or is it a different entity. And that may be a good reason to do a bone marrow. The way we think about treatment for ET has really been influenced by genetics. And I think this is an important thing for everybody to know. Historically, we used to divide patients with ET into low risk and high risk for clotting. You were low risk if you were under age 60 and never had a clot, and you were high risk if you were over age 60 or had had a clot. But in the era of genetics, we actually know that patients are different in terms of what the implications of their mutations are. Patients with a JAK2 mutation actually have a higher risk of blood clots than patients with a calreticulin mutation. And so instead of having two categories of risk for blood clots, we actually now have four based on whether or not a patient has a JAK2 mutation or a different mutation. And there's clear implications because we have traditionally said that patients with high-risk disease should have some sort of therapy to lower their platelets. But now with all of these other categories, there are patients with intermediate risk who are over the age of 60 and have a calreticulin mutation for whom all we would recommend is an aspirin and nothing more. So the way that we categorize the disease has changed in terms of the risk of having a clot, and that has clear implications for the treatment. Not everybody needs to be on treatment with a drug to lower their platelets, and not everybody potentially even needs to be on an aspirin. So something to discuss, with your physician. What about polycythemia vera? Well, in polycythemia, we have an overproduction of red blood cells, and patients can be much more symptomatic than with ET, often having itching, sometimes night sweats. Patients can have an enlarged spleen, which is not uncommon. White blood counts can be increased in patients with polycythemia vera. Essentially, most, if not all, patients with polycythemia vera have a JAK2 mutation. We don't see the other mutations as causing the disease. This disease does have a higher tendency to progress to myelofibrosis and to leukemia, And it certainly requires different management than patients with ET. So it's important to make the diagnosis. One important thing here is that I really do think patients who are suspected of having polycythemia or where the diagnosis is not clear should have a bone marrow biopsy. The reason is that there are patients who have what's called masked polycythemia, where their red count is actually normal or their hemoglobin is actually normal, but they actually are iron deficient because of ongoing bleeding from, sometimes a tumor, sometimes it's just due to heavy menstrual periods in women. But they can actually have a hidden polycythemia where the red count or the hemoglobin isn't elevated because they're iron deficient from bleeding. But in fact, if you're iron deficient, in most cases, you turn out to be anemic. The only way to sometimes make that diagnosis is to actually do the bone marrow. So I think the bone marrow is an important part of the diagnostic workup of a patient because, again, you may make a diagnosis that you wouldn't initially expect from the blood counts. How do we manage patients with polycythemia? Here we still divide patients into two camps, low risk and high risk. Low risk is under age 60 and no history of blood clot. High risk is over age 60 or history of a blood clot. And currently our recommendation is to do phlebotomy and aspirin in low risk patients, and in high risk patients to put patients on medications like interferons or hydroxyurea or ruxolitinib if they need to be. This is an evolving landscape. There are new agents in development, and I think this paradigm is likely to change in the next few years. Finally, let's talk about myelofibrosis. So myelofibrosis is characterized by a number of different things. Bone marrow fibrosis, usually an enlarged spleen, and often a higher symptom burden than we see in the other diseases. And we have to think about myelofibrosis in a much different way. Myelofibrosis can manifest with symptoms such as night sweats, fevers, feeling full early after eating, unexpected weight loss, muscle aches, a lot of different things. We also see that the spleen and the liver tend to become enlarged over time, which can become a problem. Patients can become symptomatic from that. And then there are progressive bone marrow failure that occurs. So the platelets and the hemoglobin will often drop over time. This disease can ultimately transform into leukemia, which occurs in about 25% of patients. So it is a much more frequent event and something we have to be very wary of in myelofibrosis. The way we think about the risk of somebody's disease progressing is by using a number of different tools. And I won't get into the specifics of these tools, but I think the important thing is that one has to think about myelofibrosis as a spectrum. There are patients who have really what we call low-risk disease and don't have a high risk of their disease progressing in the next 5 years. And then there are patients on the other side of the spectrum whose disease is very likely to progress in the next 5 years. And we use tools like the International Prognostic Scores, the IPSS, or the DIPSS, the Dynamic International Prognostic Scoring System, to tell us the relative risk. And this uses clinical factors like blood counts and symptoms and age. More recently, we've become a little bit more sophisticated in that we know that some mutations do have implications for prognosis. Patients with calreticulin mutations tend to have an overall better prognosis versus those with other mutations, and that the presence of non-JAK-STAT mutations like these mutations, SRSF2, EZH2, ASXL1, or IDH1 and 2, add to the risk of the disease progressing. And this has actually all been incorporated into a calculator called the MIP70 score, which takes into account clinical factors, but also the genetics to give us a more refined sense of a patient's prognosis. And I'll skip this slide, but this is just a representation showing the different prognostic scoring categories. And here's the actual tool that we use online to help make these assessments. It's a very straightforward thing, and I tend to do this with most of our patients when I'm evaluating them for the first time. So let me close with a couple of things. Here are my suggestions, at least for key questions that patients should be discussing with their physicians with regards to their diagnosis and their prognosis. One, it's always a good idea to ask for explanations regarding test results. I think that sometimes that we tend to quickly go over test results and assume that patients are understanding all of the so-called shop talk that we are giving them. And I think it is always a good idea to stop a physician and ask for an explanation of what is this test and what does it mean. It's important to ask the question, what is my diagnosis? And is there any ambiguity in my diagnosis? Remember our discussion about the boxes at the beginning of our talk today, that most things hopefully fit into one of these diagnostic boxes, but sometimes they don't. And that may have implications for how we want to treat. But I think it's important that we are clear with patients if there is ambiguity in their diagnosis. And it's important to ask this question. You should, I think, always ask, can you tell me if I have bone marrow fibrosis and how much do I have and what does it mean? It's important to ask the physician, can you review my cytogenetics with me and explain what it means? And then can you review my mutation results with me and explain what they mean? So these, again, are the central diagnostic tests that we do in most patients with MPNs. But I think it's very important for patients to be made aware of the tests that have been done and what their implications are. And my last thought, overall closing thought, is that our overall goal for MPN patients remains to help patients live the longest life possible with the best quality of life possible. That, to me, is our central goal in how we treat the disease and how we should think about treating the disease. And along those lines, I want to emphasize the message that I think we're on the verge of unprecedented changes in how we treat MPN. I think there has been tremendous progress over the last few years, thanks to the entire community at large. And we are really seeing the results of all of the scientific and clinical studies that have been invested in the last number of years. And we're really seeing things that look like they may have the potential to change how we treat this disease and to help us to advance the goal that I listed in the first bullet point, which is to help patients live longer and better. So with that, thank you for your attention.